Thank you, Madam, for the opportunity, and I would also like to thank Dr. Rohit for this opportunity to present our work on customized cross-linking. So the first question we have to ask ourselves is, why customized? BRILLOUIN microscopy studies have shown that when it comes to a keratoconic cone, the area away from the cone can behave very similar to that of a normal cornea, and that keratoconus is more probably a focal disease, at least to begin with. And additionally, computational models have also shown that selectively inducing stiffening in the weak area of the cone will flatten the cone and thereby improve the visual function. This has been made possible by the advent of the Avidro 2 mosaic system, and which also gives us broad beam as well as specific patterns. You can have customized patterns, as I will show you subsequently. And very central to this treatment is the presence of integrated eye tracking, which is extremely important for us to off-center the treatment over the area of the cone. You can use various patterns like sector patterns like this or concentric circles. In our study, we have used concentric circles and explained why. We can use the centration either on the curvature or over the thinnest point of the pachymetry or on the posterior float. We have used the maxima of the posterior float as the central point. The reason being, this is the only point which is unaffected by the variation in epithelium, as was very nicely elucidated in the previous presentations. We did it in 30 eyes of customized CXL and 30 eyes of standard CXL, which was compared with a minimum follow-up of 6 months extending to 1 year. These are some case examples where you can see that the IS asymmetry has come down to 7 diopter, from 7 diopter to as low as 1.2 diopter, providing excellent regularization in the anterior sagittal curvature. And you can see here that the cone is almost disappeared after this customized cross-linking. Even in this patient, within the central 3 millimeter zone, a marked improvement in the symmetry. When we compared the head-to-head between the CXL and customized CXL, the improvement in the IS asymmetry, the extent of regularization, the amount of flattening of Kmax and the flattening of Kmean were all statistically significant in the customized CXL group. We also got demarcation lines at various levels, the deepest being the area where you delivered the maximum energy and being progressively more superficial and patchy with the outer zones as the amount of energy delivered went on progressively decreasing. It was also important for us to look at the endothelial counts. We are now delivering a much higher energy over the thinnest part of the keratoconic cornea. And we were able to see over the follow-up of 6 months that there was absolutely no change in the endothelial count from baseline, and the haze formation, despite delivering higher energy, was comparable to that of the standard cross-linking group. I'll quickly run through cross-linking for low refractive errors as well, which is gaining prominence in the form of photorefractive intrastromal cross-linking or pixel, where you can use different customized patterns. Earlier we have done the initial trials for myopic correction with a central circumscribed 3 to 4 millimeter of cross-linking. Then now we are also trying it out for paracentral cross-linking, where you can try and treat hyperopia or some presbyopic corrections. And arcuates have also been tried for astigmatic correction. This is an example of a patient with a low spherical error, where you can see post cross-linking, you can see the central flattening in this picture. The way forward, we also thought about whether would oxygen supplementation help, and will corneal biomechanics have a role? Will a weaker cornea have greater stiffening and a greater myopic effect or not? So the first question, where we tried with oxygen supplementation, where a high amount of oxygen, though this may not be the best way to deliver oxygen, but this was what was best available and could be done. We saw that when we compared our results with previously published literature, that oxygen did have a benefit, because we had followed the same protocol as previous publications except for oxygen, and we had a greater change in MRSE and a greater amount of flattening as compared to previous studies. With regards to the second question, whether biomechanics had a role, we could not find a linear correlation where weaker corneas had a greater refractive effect or not. So this did not really make a difference, at least in this subset which we studied. So in conclusion, with use of customized cross-linking, by using predictable patterns, we can give rise to predictable results, which augurs for better refractive and keratometric outcomes. And maybe in the future, we could combine this customized cross-linking with custom topo-guided treatment as well, and further augment the results in our keratoconic patients. Thank you for your patient hearing.
Thank you, Shreyas.